you I'd play something from the century. So our last section of this chapter, which will also wrap up Unit 1, we need to talk about the intrinsic conduction system of the heart and how that is read on an ECG, and then some homeostatic imbalances that can be seen on an ECG. So before we launch in, as always, kind of just sit back. I want you to kind of absorb where we're headed.
The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Okay, so that's a good one to watch over and over again, and I will put that link for you in your checklist, because sometimes that just kind of takes more than once. All right, so this diagram, just what we watched when they showed the yellow, we got the SA node, the AV node, the AV bundle, the bundle branches, and then the Purkinje fibers. And so all of that makes up what's called the intrinsic cardiac conduction system. I call it clumps and strands. That is not a technical term, but these are specialized muscle tissue that they're kind of part muscle, part nervous tissue. Like I said, they are going to have an unstable resting membrane potential. They can initiate contraction without any sort of stimulation from the nervous system, the central nervous system. So it initiates and distributes impulses throughout the myocardium, coordinating the cardiac cycle. So these nodes, the SA node, which is going to be in that right atrium, just like I said, close to that entrance of the superior vena cava. and these are self-excitable. And these SA nodes, they have the fastest rate of depolarization, so they are going to be the pacemaker. There's another one that's just not as fast as the SA node, but we also have the AV node, so that's another clump of these specialized cardiomyocytes that they never rest, so they don't really have a stable resting membrane potential. When we get firing, just kind of remember we just saw that whole yellow going through. You get your action potential and then you get contraction, and so it's very, very close. Hold on. And when we talk about strands, think of them as roadways or preferred pathways for those action potentials to travel. They can travel, ions, remember, because they're all linked with gap junctions, they just travel faster through these preferred fibers. Hold on, hang with me. Okay, so this is the apex of a human heart in surgery. So even though you think, so let's see, let me click back just 1 second. So what you're looking at, just imagine I lopped this off and I just stuck it to the side. We don't have the SA node or the AV node, but we have some of these preferred pathways. And remember, 1% of the cells are auto-excitable, so they're self-excitable. So let's go ahead and see what happens. Okay, so we have those self-excitable cells. They're depolarizing due to those gap junctions. Those ions are moving. So we've got sodium moving, calcium moving, potassium moving, and we get either the heart beats all together or it doesn't. So in this case, yes, we're just looking at the ventricles, but notice there is no external autonomic nervous system stimulation. All right, so we're going to go through the intrinsic cardiac conduction system. So it all starts with the sinoatrial node, or the other name is the SA node. I want you to remember that that is the pacemaker because I'm going to ask you what is the pacemaker. So come down here. So this is showing the action potential of that SA node. Remember down here, this is resting membrane potential. I want you to see that it never really rests, like it never really stays there. And pop over here. So this is my analogy for you. So I don't know if you've ever been to a water park where you saw the big bucket. And so the big bucket, it just drips, 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 and it slowly fills, and eventually it just falls over. All right, pop back down here. So we are going to have, so down here we have reduced calcium permeability. Don't worry about that. But we're going to have sodium ion channels that are dripping. So we're going to drip sodium in, which is going to make us get closer and closer to the threshold. So imagine my little big bucket. So I got drip, 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 sodium moving in, sodium moving in, sodium moving in. As soon as we reach threshold, then we got calcium is going to rush in, the calcium gates are going to close, then potassium gates are going to open, so potassium is going to rush out. And so we get our action potential. So this would be one action potential, we'd have a heartbeat. Then drip, 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 so slow depolarization, pacemaker potential, we reach threshold, depolarization, repolarization. And so this is time. So the amount of time it takes to drip is going to set the rate of the heartbeat. So the sinoatrial node, the reason why they're called a pacemaker is because they have the fastest rate of depolarization, meaning their bucket fills up faster than the AV node, than the AV bundle, than the bundle branches or anything else, or just the cardiac muscle itself. So that's why it gets to be first, because it's the fastest. That's why it's the pacemaker. So they are self-excitatory. So your resting heart rate is approximately 70 to 80 beats per minute. So 75 beats per minute. So this is what is called sinus rhythm. Because it's a sinoatrial node, the pacemaker is in charge. Without neural control. I don't want you to think that the central nervous system is not involved in controlling heart rate, because it is. Normally, parasympathetic innervation is in charge because most of the time life is not that exciting. So kind of think about like driving with your brakes on. The brakes are always on this SA node because the intrinsic conduction rate, if you take the brakes off, so the vagus nerve, cranial nerve 10, stops releasing acetylcholine, the normal beat of the SA node is about 100 beats per minute. So really your brakes are always on, and think about it when you start to exercise and you need to raise that. All we need to do is reduce parasympathetic control. So just kind of let up on the brakes. We also have some gas. We're going to talk about that in the next unit, but SA node is the pacemaker and sets that resting heart rate. So from this SA node, once we get depolarization of the SA node, then that action potential is going to spread across the atria. And this is where that cardiac skeleton comes into play. The atria are electrically insulated from the ventricles. So we get action potential, and then that message, so those action potentials are all going to come back around and pause right here at the atrioventricular node. So right there. So impulse pauses at AV node. The reason for that is we kind of spread out, and then now we have merging traffic. So there's a small diameter of nerve cells. If you've driven around Houston, you know that if there's lane closures and you go from 5 lanes to 2 lanes, everything slows down. The functional reason for this slowdown and this pause of the AV node is once the message gets here, then we get atrial systole, we get atrial contraction. Remember, we want the atria to contract before the ventricles contract. So we get atrial systole, and then that message is going to go down that atrioventricular bundle, or the bundle of His, and then it's going to branch. So we're going to have a right bundle branch and a left bundle branch, and then it's going to take that message to the ventricular myocardium through, and this is not taking off, but subendocardial conducting network. That is a mouthful. So it does tell you, though, it's beneath the endocardium, and it is a conducting network. That's awesome. But the other name for them is Purkinje fibers, and that one is just sticking because it's so much shorter. So the man Purkinje identified them, got to name them after himself. But what they're going to do, their job is to stimulate ventricular contraction via those gap junctions, and then we get ventricular systole. I will tell you that ventricular systole begins at the apex, so this part is going to contract first, and that makes sense because we're trying to force blood up and out those semilunar valves. Hold on, let me take that. There is a structure that isn't shown on here called the moderator band. So remember how the heart is situated in the mediastinum. This is actually kind of pointing over to the left, and this heart is more laying down. In order for blood to go up and out that pulmonary trunk, we kind of need this wall to get the message first, as opposed to the point. So we need this to kind of contract first, lead in to force it out. So there's a structure in a human heart called the moderator band, and it's just a piece of flesh that is basically going to take that message from the interventricular septum over to that right wall of that ventricle, so the right ventricle. And let's see. And so we just get that little movement of the wall before the apex. And that's just specifically on the right side, just to make sure blood goes up and out. So the instrument that measures all of these ion movements, because you think electrons, ions are moving, so it's electricity. The instrument is called an electrocardiograph, and then the readout is called an electrocardiogram. ECG is the same as an EKG. The man that came up with this was German, and cardio in German begins with a K. And so that's the difference. But EKG is the same as an ECG. On your lab list, I'm going to ask you, what is this picture? You're going to write, oh, it's an electrocardiogram, ECG. So electrocardiograph, it's a fancy voltmeter. And so there's going to be leads placed on the body. So each lead measures current from the heart at a different angle. So think about an ECG as an electrical snapshot of the heart. And so what these leads are doing is they're taking a picture from a different direction. Just like if I put a vase of flowers in the middle of the room and said, hey, take pictures of it, you could come at it from all sorts of angles to get a different view. And that's the function of the different leads of an ECG. The tracing that you see, so we have this part is called the P wave. So we have a P wave, we have QRS complex, and then we have a T wave. So if you can remember your alphabet, P, Q, R, S, T, you're fine. So each feature of an ECG gets a name. So pop up over here. So we know that the SA node depolarizes first. So when we get depolarization, remember we have sodium moving, calcium moving, and potassium moving. That can be read on the electrocardiogram. And so here we have the P wave, and it's showing you that depolarization is spreading. So this P wave represents atrial depolarization, which we know is going to be quickly followed by atrial contraction or atrial systole. Then we have that pause at the AV node, and so that's why this is the baseline, so nothing's going to happen. And it's going to pause there, and it's going to go down the bundle of His, or the atrioventricular bundle, right and left bundle branches, till it gets to the Purkinje fibers. Once we get to the Purkinje fibers, now it's going to spread out to the ventricles, and so we have the QRS complex. So now all of the ventricles have the message, and then we're immediately going to get ventricular contraction. And so the QRS complex represents ventricular depolarization and ventricular systole. Then we've got the ventricles contracting, they're doing their thing, and then we get the T wave. Notice I don't have another picture for that, because the T wave is just showing you repolarization of the ventricles. The atria also repolarize, but they're repolarizing at the same time the ventricles are contracting. The atria are much smaller. There's not a lot of ion movement. It's somewhere in that QRS complex, so it gets masked. So P wave, atrial depolarization, QRS complex, ventricular depolarization, and the T wave, ventricular repolarization. And so I gave you this picture. And so just keep in mind, muscle contraction closely follows that depolarization. So it's showing you atrial diastole, we get the P wave, we get atrial systole, we get that pause, and then when we get the QRS complex, we know that the atria are in diastole, then we're going to get ventricular systole, we get repolarization, the T wave, and then we know they both rest. And so this is just kind of showing each time you see a P wave, QRS complex, T wave, that is one cardiac cycle. So some things that can be seen on an ECG. So if someone comes in or they go for a heart checkup, they're going to do an ECG. There's some things you can see and there's some things you can't see. Like you can't see anything wrong with the valves on an ECG. So that would be through auscultation or some other method to specifically look at the valves. But this up here, notice we have a P wave, we have QRS complex, T wave. P wave, QRS complex, T wave. So each one of these P waves, QRS complex, T wave represents one cardiac cycle. These boxes represent time. And they represent time because the paper speed going through the electrocardiograph is going to be set roughly at 25 millimeters per second. So as a result, these big boxes, they are going to be about 0.2 second intervals. And so a normal sinus rhythm and pace, we are going to get a cardiac cycle that will last from 3 to 5 big boxes because we have a normal rate of 75 beats per minute. There are some homeostatic imbalances with rate. So if someone has a resting heart rate greater than 100 beats per minute, that's called tachycardia. If they're exercising, it's over 100, that's fine. But at rest, no one's heart rate should be over 100 beats per minute. And so that could be seen on an ECG. And so you would look, the easiest way to just quickly visually see it, you would go from the tip of, so QR, so from R to R, And you can see here, oh, we are less than 3 boxes. So you can see these cardiac cycles, those QRS complexes, they're really, really close together. And so that's tachycardia. The problem with tachycardia is that if this is too rapid, there's not enough time for ventricular filling. And if it's persistent, it can lead to fibrillation or an uncoordinated beat. So normal sinus rhythm, we get adequate cardiac output and blood supply to the tissues. But if it's too fast, there's not enough time for ventricular filling. Our stroke volume is going to go down and we won't get enough blood delivery. You can also have the other side. You can have too slow of a heartbeat, and that's called bradycardia, so under 60 beats per minute. And since this represents time, now we're going to have more than 5 big boxes from the tip of the QRS complex to another QRS complex. And so what this can do, if the heart beats too slowly, grossly inadequate blood circulation, and this would be in non-athletes. If someone is an endurance trainer, they can actually have a heart rate lower than that. But you could easily visually look at your patient and know if they were an endurance trainer. What happens during endurance training is that the heart gets more efficient per beat, therefore it doesn't need to beat as often. But that's clearly distinguishable if you look at somebody. And you can also ask them, and you take them through patient history. So we said that the heart beats either as a unit or not at all, but there are uncoordinated heartbeats. And so once again, up here we're looking at a normal sinus rhythm, and we know it's normal because we see all of our ECG features. So P wave, QRS complex, T wave. There's something called atrial fibrillation, and that's when there's multiple P waves before a QRS complex. And so if you kind of look at this ECG, you see the big peak. So you see a QRS complex, but then it looks really messy leading up to it. So this would be atrial fibrillation. The problem with atrial fibrillation is that those little auricles, I don't know if you could tell that in the picture, but they kind of hang down. Like you can actually pick up a heart by its little ear flaps. And if the atria aren't contracting, they're not moving the blood downstairs, the person's still moving enough blood because the ventricles are really way more important than the atria. But, so now you have blood pooling in those little ear flaps inside the atria, so inside those small chambers. And so you can get inappropriate blood clotting. If those inappropriate blood clots then they move, so they're an embolism, and they get trapped in the pulmonary circuit, that can cause death. But atrial fibrillation is not as serious as ventricular fibrillation. I'm not saying AFib is good. There's always that risk of blood clots, and someone with AFib is going to be placed probably on a blood thinner. But ventricular fibrillation, you can see there's no blood being ejected here. This is not a coordinated beat. So a very chaotic rhythm. You can visually see the difference. This leads to cardiac arrest. Cardiac arrest is not the same as heart attack or myocardial infarction. It means it can lead to the heart stopping and not pumping blood, so it leads to death. This is why you see these defibrillators, because if this is occurring with someone, there is not time. What a defibrillator does is it delivers a jolt of electricity that the idea is it will completely reset or depolarize all of the heart at the same time. And what one is hoping is that that SA node, the pacemaker, will then pick up a normal sinus rhythm. And so that's the purpose of that defibrillator. So if I ask you on your test which is more serious, atrial fibrillation or ventricular fibrillation, I hope you can see this little tombstone here. So it's definitely ventricular fibrillation because it's the ventricles that are responsible for ejecting blood out of the heart. There's some other things too with rhythm. So an arrhythmia, this is cardiac cycles having varying duration. And so you can kind of see like, oh wait, these are 6 boxes apart, these are 4 boxes apart, these are 3 boxes apart. And these usually aren't a problem if it is a normal sinus rhythm, meaning there's a P wave, QRS complex, T wave. There's certain pathologies that if you have so many runs in a row and it looks a particular pattern, that could mean pathology, but for the most part, sinus arrhythmia is not a clinical issue. A lot of people have arrhythmias due to either too much caffeine, not enough sleep, stress. So little runs of arrhythmia usually are not a problem, but A without rhythm. So cardiac cycles varying duration. There is a certain type of arrhythmia, though, that does mean that there's a problem. And so it's called AV heart block. And so just what it's implying, AV like the AV node, there's a blockage in the road. And so we go SA node to AV node, the atria contract, but it's supposed to go AV node and go down that interventricular septum and then stimulate the ventricles to contract. So look down here with me. So we have a P wave and we have a whole lot of time. So we have this really long PR interval. So too much time is passing. So it's kind of like congested traffic, a block in the road, AV block. Oh, and then we finally get depolarization of the ventricles. And then we get repolarization. And then we have our P wave. So SA node fires. And then it pause, blocked at the AV node. Okay, ventricles got the signal, QRS complex. T wave, so we get ventricular contraction. And then look, we have P wave. Nothing. It was blocked. That message got blocked to the AV node. It never made it to the ventricles. The SA node tries again. That one made it through. And so this right here, AV heart block, that is something, it is serious, and usually they're going to give that person an artificial pacemaker. Because what can happen is if this gets, look how slow that is. The heart is just, the blood is going to be stagnant. It can be too slow for life. The ventricles will kind of stimulate their own beat because they're self-excitable as well, but that's down to 30 beats per minute. So if they don't hear from the AV node, they're gonna beat just like that little apex sitting on the table, but that's not fast enough. So they'll have to use an artificial pacemaker if someone has AV heart block. There's several different types of heart block. You can learn more about that when you advance in your studies. So our last part, I kind of want to talk about myocardial infarction and an ECG and sort of that progression. So if someone is having chest pains, and that would be a sign they may be having a heart attack, they could feel chest pain, pain in their upper shoulder due to referred pain, sometimes pain in the jaw on the left side, or pain in the neck on the left side. Usually that person would be kind of pale, they're not going to feel very well, and may even be sweating. So progression to a heart attack. So once again, this is going to be a problem with that coronary blood supply. So the first thing that's happened is ischemia. So that's low oxygenation to the tissues. If that continues, then we're going to get injury to those tissues. And if that blood flow doesn't get restored, then we get cardiac muscle tissue death, which is an infarction. So people go to have a stress test, and what they do is they hook a person up to an ECG and they have them walk on a treadmill. And so they're trying to increase oxygen demand. They can actually see if the heart circulation cannot supply or isn't being supplied with oxygen in that exercise stress-induced state. And so they'll actually see this T wave start to dip down. So they can read ischemia on an ECG. So they would have that person stop at that point, and then they would probably do an angiogram and check the coronary circulation. But keep in mind, so prolonged ischemia leads to injury because cardiac muscle relies on aerobic respiration to make ATP. So you can go from ischemia to injury. So an acute myocardial infarction, heart attack in progress can also be seen on an ECG. So STEMI, maybe you heard STEMI, that stands for STElevated myocardial infarction. And this is usually due to a total blockage of a major vessel. The number one is that left anterior descending artery or that anterior interventricular artery. And so remember QRS, and normally we get a flat line and a T wave. So this is a really easy, there's different ones, but the ST is elevated off that baseline. So that's what a STEMI is. So that if there is a major artery that is blocked, what's going to happen is that is going to then block delivery to the myocardium. And delivery is from the endocardial side out. So first, the blockage is going to show in that inside. So this is the wall. Think of like you put murals on a wall. So submural, and this is transmural. So this is all of this muscle tissue is deprived of oxygen, and if it stays that way, it's going to die and it won't come back. So you could see a STEMI, they would know right away. If it isn't a STEMI, it doesn't mean something's not right. They just wouldn't be able to see it. And so they would verify it using an enzyme panel. And so they would look for elevated cardiac enzymes, which would show tissue damage. Once again, if it's in progress, they would give, oh, we talked about it, so TPA, so tissue plasminogen activator, to dissolve that clot. Without the restoration of blood flow to the injured myocardium, that part of the muscle will die. And like I said, it affects the subennial cells first, so and then goes towards the epicardial side. I gave you the answer. So what fibrinolytic drug could the patient be given to dissolve the clots? Oh, I hate it when I give you stuff like that. My bad. So TPA, so tissue plasminogen activator. Remember, that is a fibrinolytic. It can dissolve a clot, and the idea hopefully restore that, and then they can do a bypass or put in a stent. Cardiac enzyme blood levels. This is, keep in mind, once again, we're talking about muscles. So we have myosin, we have the troponin and tropomyosin. Normally these would be inside of the cell, but whenever there's tissue death or ischemia-induced damage, then we get release of those enzymes and they can be read in the blood. So these proteins should be inside of muscle cells. They're released due to injury of myocytes. So that if they couldn't see a STEMI, they would still follow up with a blood panel. And then as someone's having a heart attack or had a heart attack, they would also continue to take these blood levels over time to assess the amount of damage or degree of damage to the heart muscle. After someone has had a heart attack, particularly a transmural heart attack. So transmural heart attacks leave what's called a pathological Q wave. So remember, it was QRS. And so a Q wave, if it is exaggerated or drops down too deeply, then someone who is, trained to read these would know, oh, I see you've had a heart attack in the past. So past heart attacks show as well. So a pathological Q wave shows that transmural heart attack, because think about it, if cardiac tissue muscle, it dies when there's too much injury, then there's also no ion movement, so it would not be read on an ECG. So they could even tell, depending upon which lead, where in the heart that person had their myocardial infarction, so where that dead tissue was. We did it! So congratulations, you're done with your first unit. So this ends the material for exam 1. As always, be sure to study your notes, look over the PowerPoint, and then I prepared Quizlets for you. Good luck, and as always, I'm here if you have any questions. Have a great day.